Hello, and welcome to another live broadcast with MedStar Health. My name is Amy Cameron. March is Colorectal Cancer Awareness Month, and we're here to talk about something that could truly save lives: colorectal cancer screening and prevention. Colorectal cancer is one of the most common cancers in the United States, but when it's caught early, it's highly treatable. Knowing your risk and getting screened at the right time can make a big difference. Today, I'm joined by 4 experts from MedStar Health who will help break down what you should know about colorectal cancer, including the risk factors, signs and symptoms, screening options, and ways to help reduce your risk. Joining us today are gastroenterologist Dr. Nikki Asamoah, Dr. Waleed Shaloub, and Dr. Ripple Mehta, an internal medicine physician and physician lead for MedStar Health's colorectal cancer screening performance program, Dr. Jennifer Tran. Thank you all for tuning in, and let us know in the comments where you're watching from, and feel free to share this broadcast with your friends and family. And if you have any questions during our conversation, just drop those in the comments and we will try to answer as many as we can live. Before we begin, let's learn a little bit more about our panel of experts. Dr. Asamoah, would you start, please? And thank you so much for joining us.
Thanks for having me. So I'm Dr. Nikki Asamoah. I am at MedStar Health Washington Hospital Center in Georgetown University Hospital. I'm a gastroenterologist with a focus on inflammatory bowel disease, but I see all patients and perform procedures for colon cancer screening on a regular basis.
Awesome. Thank you. Dr. Shaloub, would you go next?
Of course, my name is Dr. Waleed Shaloub. I am a gastroenterologist as well in the MedStar system. I work out of Georgetown University Hospital and out of Southern Maryland. I'm the site director for the GI division here at Southern Maryland. I'm the program director for advanced endoscopy at Georgetown. I've been with the team for a very long time, but my focus is pretty much pancreatic or biliary diseases, but I also do colorectal cancer screening, and I'm very happy to raise awareness today with this Facebook Live, and I'm looking forward to all the questions from everybody watching.
Awesome. Thank you. Dr. Mehta, thanks for being here. Oh, Dr. Mehta, I think you might be on mute. No, we cannot hear you. Dr. Tran, would you go next and we'll try and get Dr. Mehta back.
Thank you, Amy. I'm Jennifer Tran. I'm a primary care doctor at MedStar Washington Hospital Center, but I also lead the colorectal cancer screening performance program for primary care. I'm really passionate about preventative health and colorectal cancer screening, and really believe that everyone should be given the best chance at achieving their best health. So I'm really happy to be a part of this. Thank you.
Thank you so much. Dr. Mehta, let's try again.
Okay, can you guys hear me now?
Yes, there you are. Perfect.
All right, wonderful. Amy, glad to be here. I'm Dr. Ripple Mehta. I'm also one of the gastroenterologists in MedStar Health. I practice general gastroenterology with special interest in colorectal cancer screening, prevention, and awareness, as well as the surveillance of it. Currently, I practice at MedStar Southern Maryland Hospital, St. Mary's Hospital, and at our Brandywine Surgical Center.
Amazing. Thank you so much for being here. Let's get into some questions. We'll first start talking about risk factors. And what is colorectal cancer? Dr. Mehta, could you answer that one?
Yes. So colorectal cancer is actually the growth or a tumor that develops from the inner lining of the colon or rectum. Collectively, we call it large intestine, which is the colon, rectum, and anus. So any growth or a tumor developed from there is considered colorectal cancer.
Great, thank you. Is there a difference between colon and rectal cancer? I know we call it colorectal.
Typically speaking, yes, there are some differences. For example, they develop from different type of cells. They are at different locations. Treatment is quite different for both of them. However, when we talk about the screening of it or the surveillance of it, diagnosis of it, it's basically the same. The same area and the continuum is same. So for that matter, it's considered the colorectal together.
Okay, that's helpful. Why are more people under age 50 developing colorectal cancer? I know it's been really in the news a lot lately.
I agree that, and that's actually a very great question. We've been also looking for answers for that. We definitely have seen the trend moving more towards the younger generation. And when we consider for colorectal cancer perspective, the younger population is typically considered 50 or below. Colorectal cancer typically was considered a disease of fifth or sixth decade, but lately we have some observational studies that we have been finding more and more either high risk polyp or the cancer in more younger population. We don't really have an exact final answer at this point. There are several risk factors that's associated with it. For example, tobacco use could be a potential factor for that, alcohol use, lack of physical activity, obesity, lack of fibers in your diet. Processed meat is also one of the consideration. There are several other they're under study at this point, but we don't really have a final answer, but definitely there is a trend like that.
Hmm. What are the risk factors and the role of genetics in colorectal cancer risk?
So risk factors is any factor that basically gives you the possibility of developing colon cancer or rectal cancer. Uh, so the way I explain this to my patients is there are two categories. One we consider average risk, and the other one is considered elevated risk. Average risk is just based on the observational studies or whatnot. We have a state-of-art guidelines that recommends that everybody who's at average risk, meaning they don't have any family history, they don't have any personal history, and they don't have any symptoms, completely asymptomatic, otherwise what we consider a healthy person. We should start the screening at age 45 because that's when we see the trend is going up. The other category, as I discussed, which is elevated risk category. To better understand I also understand this in three different categories. The one is what we consider hereditary syndromes. For example, Lynch syndrome, where we know that there are some gene mutations where they really play a role in this one, and you have not only elevated risk of developing colon cancer, but early in age, much early. For example, Lynch syndrome, we consider starting colon cancer screening for them as early as 20 years old, 15 years old. The other category is either personal history or symptoms or family history. For example, first degree relatives such as mother, father, brothers, sisters, if they have high risk polyps or if they have developed colon cancer, especially at younger age, meaning if they had it at the age 50 or below, you are definitely considered a elevated risk patient, and you should talk to your either primary care physician or your friendly neighborhood gastroenterologist and get the screening started as soon as possible. And the third is what I consider is everything else. One of those everything else is worthwhile talking is something what we call inflammatory bowel disease, like ulcerative colitis or Crohn's disease. We know that these are chronic diseases. They produce a lot of inflammation. There is a lot of cell turnover, and that definitely puts you at a higher risk of developing colon cancer.
Okay, thank you. And you kind of mentioned this, but if someone has some of the risk factors you mentioned, what's the first step? So either you said going to their primary care provider, or would they consult a gastroenterologist first?
So if somebody has symptoms, for example, if somebody's having loss of appetite, not putting on a weight, or losing unintentional weight, we are going to talk about the signs and symptoms a bit later. I think Dr. Chalu will explain this. Uh, if there are symptoms, I think getting to a gastroenterologist to get it evaluated and to see what we need to do. Is there a CT scan needed? Is there a colonoscopy needed? Is there upper endoscopy needed, or both? That is important to understand that. If you found out that you have a family member who had some polyps or colon cancer, reaching out to your primary care or your gastroenterologist, both of them are reasonable. They both can help you. Primary care physician definitely can also refer you to a gastroenterologist where we can have this further discussion, we can further risk stratify, and then we can help the patient out for the screening process.
Okay, that's really helpful. Moving into some signs and symptoms, it's been said that colorectal cancer often has no symptoms. How do you know if you need to see a doctor?
Thank you for the opportunity to jump in here. So let's talk about something that's incredibly very important, the signs and symptoms of colorectal cancer. The biggest sign and symptom of colorectal cancer is that people have no signs or symptoms that happen early on. And that's why screening colonoscopy is very, very important. But when symptoms do occur, there's several warning signs that patients should never ignore. The first one, and the one that most patients come to us for, is rectal bleeding. It's one of the most common symptoms people notice, obviously, because it's a change. They see blood in a place that blood should not come out of. It can appear as bright red blood on the toilet paper. It can appear in the toilet bowl. It could appear mixed with stool, on the stool, covering the stool. So the different ways it can appear in once you go to the bathroom. It can look darker. Some of it doesn't have to be red. It can look darker. It can also look maroon colored, depending on where the bleeding's coming from, the GI tract. One thing I always tell patients is this: never assume that bleeding is just hemorrhoids. Most patients think, oh, it's just my hemorrhoids acting up. Or, you know what, women of childbearing age who have already given children, oh, yeah, it was my hemorrhoid. Never, ever underplay a symptom of rectal bleeding. They're very common. Hemorrhoids are very common, but any persistent rectal bleeding should be evaluated specifically in adults over the age of 45. In adults at any age, I'm thinking now, just because now we see in so many younger patients, but specifically in adults over the age of 45. Another symptom that I'd like to touch on is change in bowel habits. So it's just an important thing to notice if your bowel habits have changed, and this could be things like new constipation or persistent diarrhea or alternating constipation diarrhea, or you look at your stool and you see that your stool, like the caliber of the stool, is either narrower or thinner than usual. Is it like squeezing through a little, a mold to make it look like a pencil, for example? And these can happen when a growth or tumor begins to narrow the colon, which affects how stool passes through the colon and how it comes out of us as humans. There's a symptom that surprises a lot of people, and some colon cancers bleed slowly over time. So some patients may not see any visible blood. It doesn't have to be like frank blood in your face, but instead they start developing iron deficiency anemia. And these patients present with things like fatigue, weakness, shortness of breath, feeling tired. Before they could go up the stairs, in a second, and now they feel winded going up the stairs, and that could in itself not be anything related to your lungs or anything. It could be related to the slow ooze or blood coming out of this colon cancer in your colon, and it comes to a point where you start manifesting like that. Other symptoms are actual pain, abdominal cramping, or just abdominal pain. I wouldn't let those go. Patients experience persistent abdominal pain, cramping, bloating because they can't let stool out of them. They start bloating up more. This can happen if tumor begins to irritate the bowel or partially obstruct it, okay? And what's more important here is the persistence or the worsening of the pain. That's it's not an occasional stomach ache. Not everybody with a little stomach ache needs to get home. It's just that this persistent worsening stomach pain that needs to be evaluated. And just as Dr. Mehta was saying, the unexplained weight loss. When people just start shedding weight, they're like, oh yeah, I'm happy. Watch what you wish for. It's very important that people really watch what they wish for. It's a red flag. If someone's losing weight without trying or changing their diet or going to exercising, that should be evaluated right away. Cancer can change how the body uses energy, and this can lead to the weight loss. So all the energy that we, let's say, used to eat a specific amount of caloric intake a day, the cancer just consumes it. It's such a very, very rapidly growing, very active, dynamic illness inside of you that it consumes everything you eat, and that's how you do lose the weight. So it's just a key thing I want to emphasize is how many symptoms do I need before I see a doctor? Right? Do I need all 5 of them? Do I have to be losing weight and short of breath and bleeding? And no, the answer is no. You don't need multiple symptoms. Even one persistent symptom should prompt evaluation, specifically if it lasts more than a few weeks.
Okay, that's really great advice. Of those signs and symptoms, what would you say are the most common?
Rectal bleeding,
Okay.
abdominal pain, those are ones because those present, frankly,
Mhm.
anemia is in patients who've been bleeding for a longer time. Usually, it does present, but just not as fast as the others.
Okay.
You know?
And what usually happens when a patient presents with these symptoms? Do they get a colonoscopy right away?
So definitely clinical evaluation. So just also piggybacking on what Dr. Mehta was saying. You asked the question, who do they see first, the GI doctor or they need to see a doctor, like the fastest access. We need to get them into the system as soon as possible. So in many cases, usually the next step is a colonoscopy because a colonoscopy is very good in terms of direct visual examination of the colon to identify the growths, to remove the polyps, and to take the biopsies if needed. So it's both a diagnostic and a therapeutic exam at the same time. So that's why colonoscopies, when you do present with symptoms like that, can actually prevent cancer by
Okay.
removing precancerous polyps before they actually turn into cancer. The whole point of a colonoscopy is to prevent it. Just
Hmm.
like, mammograms back in, I don't know, 1950s came out, how they turned everything around in breast cancer world. Colonoscopies save lives, period. If that is one thing I would like, is colonoscopy save lives. I'm not going to jump on Nikki's or Jen's subject, but yes.
That's
So, yeah.
That's really helpful. What can happen though if you ignore these symptoms and don't seek treatment?
The big C, you'll get, you'll get cancer. And it's, as I said before, it's something totally preventable. And just what Dr. Mendel said with risk factors. So if you're having symptoms and you have, your father had colon cancer at 52, or you're hearing all over the place that, your 37-year-old friend who was a mother of a 4-year-old just developed like this rectal cancer. It's just things that are coming. If you miss, you will be sorry for it, I think, because hindsight's 2020. If we continue and we raise awareness and we make sure that people are getting what they need to get on time, it's a preventable death. I'm not going to say preventable cancer, it's a preventable death.
Yeah. Wow. For those of you who have just joined us, welcome. We're live with our experts discussing colorectal cancer awareness, risk factors, and the importance of screening and prevention. If you have a question for our panel, feel free to drop it in the comments, and we'll try to answer as many as we can during this broadcast. So let's continue our conversation and talk about screenings with Dr. Asamoah. At what age should patients talk with their doctors about a colorectal cancer screening?
So in 2021, the U.S. Preventative Task Force released new guidelines recommending colon cancer screening for average risk individuals beginning at age 45. It's important to note that when we say average risk, we mean the general population, people with no known risk factors that my colleagues talked about, or those with no symptoms of colon cancer. In a recent MedStar survey, 4 out of 10 people thought this only applied to those with a family history of colon cancer. As my colleague mentioned, if you have symptoms or a family history, you may need a colonoscopy sooner than age 45, but the current guidelines recommend screening starting at age 45 for the average population.
Okay. What types of screenings are available besides colonoscopy, like we've discussed?
Colonoscopy is the gold standard for colon cancer screening. It offers the added benefit of being able to find and remove small precancerous growths to prevent cancer, but some people may want to avoid colonoscopy. In that case, the other guideline-based screening options include stool tests, so Cologuard and FIT tests. These are non-invasive at-home stool tests that can be collected and submitted to a laboratory. These tests detect microscopic amounts of blood in the stool, and for Cologuard can detect altered DNA as well, which may be associated with colon cancer. Lastly, CT colonography is another colon cancer screening option using an abdominal CT scan, but still requires a bowel preparation similar to a colonoscopy.
Oh, okay. Let's talk about the PrEP, colorectal cancer preparation.
Absolutely. So colonoscopy prep is probably the most difficult part about the entire procedure, but it's the most important part of your colonoscopy. In order to detect cancer and precancerous changes, your colon needs to be properly cleansed. Historically, this meant altering your diet for several days, fasting with only clear liquid diet for 24 hours or more, and drinking at least 4 liters of laxative solution to clear out your colon. But guidelines released last year by 3 major gastroenterology societies suggest that this may not be necessary. So the new guidelines provide recommendations that makes the bowel prep a little bit more tolerable. So a few things. One, you can limit diet changes to a few days prior to a colonoscopy instead of 1 to 2 weeks as previously recommended. Number 2, you can allow people without constipation or other risk factors for an inadequate bowel prep to eat a light meal in the morning 1 day before your colonoscopy. This is not standard practice just yet because it's difficult to assess which patients are at risk for inadequate bowel prep, but this is part of the guidelines and what most gastroenterologists are moving towards. And thirdly, the recommendation is to limit the bowel prep to 2 liters of solution if possible. A lot of insurance companies cover bowel preparation, and they have started to cover these low volume preps that are only about 2 liters of solution. We also, the guidelines recommend splitting the bowel prep in half the night before and the morning before your procedure. So one night before, and then on the morning of your procedure, you'd be drinking half of the 2 liters and the other half in the morning. It's important to note that these guidelines do not apply to those people who have constipation or other risk factors for inadequate bowel prep. And that's something that our gastroenterologists can figure out in their pre-screening questions.
Okay, that's helpful. Can you give us an overview of what happens during a colonoscopy?
Absolutely. So during a colonoscopy, once the medical team reviews your medical information, you're usually taken into a procedure room. You're provided anesthesia medication that typically makes you sleepy. Most patients are still breathing on their own during the procedure and don't require breathing assistance during the procedure. While you're asleep, a flexible thin tube with an affixed light and camera is inserted from your bottom and advanced into the beginning of the colon. As the tube is removed, we insert air and water to expand the colon to get a good look inside of for polyps. I tell people think about kind of inflating a balloon. We want to look on the inside lining of the colon to find these small polyps or potentially precancerous growths. These can be removed during the colonoscopy to prevent colon cancer. So we're looking for polyps. We remove them at the time if they are small enough. And then once we're completely done, you will leave the procedure room, usually go into a recovery area. And then typically we monitor you for about 30 minutes after the procedure. Most people for the common anesthesia medications that we use, most people wake up within 10 minutes of having their procedure completed and are able to go home with assistance, but are able to go home and walk out of the procedure area and get back to their normal diet later that day.
Okay, you mentioned removing polyps during. Are there any other procedures that might be needed?
Potentially. So if we find a large polyp that can't be removed, sometimes we refer you to our colleagues. Other things that we can find during a colonoscopy, in addition to detecting polyps, inflammation. My partner mentioned inflammatory bowel disease, so we can find colon inflammation, abnormal blood vessels, blockages or narrowings in the colon. So lots of other things that we can detect, but our goal is for screening purposes is to pick up those polyps and remove them and try to remove them completely to avoid having an additional procedure.
Okay. Are those polyps always precancerous?
They're not.
Okay.
Certain types of polyps have been studied and have typical morphology when you look at them under a microscope that suggests that it has precancerous changes. So these precancerous changes over time lead to colon cancer. Some polyps are benign, and those types of polyps have no cancer potential and typically don't grow bigger to turn to cancer. So we look for those polyps, and there are certain things that we can pinpoint during the colonoscopy to say, okay, this looks like a precancerous polyp, including the size of the polyp, the way it looks, if it's bleeding, certain features that we can pick up during the colonoscopy. But when we remove polyps, we do send them to our pathologist for review to confirm whether or not it was precancerous or completely benign.
Okay. And when do you refer someone to a colorectal cancer specialist?
So if you have an abnormally large polyp or mass that was identified during a colonoscopy, often we do not remove it. These findings may be best removed with surgery. And in those cases, we send the patient to a colorectal surgeon for further evaluation.
Okay. All right. And Dr. Tran, let's talk more about preventative healthcare. Can you tell us about your role at MedStar Health first?
Absolutely. Yeah. My role at MedStar Health is I'm a primary care physician. So really my role is to be your advocate, to be any patient's advocate. I want to provide the best guidance, provide the best recommendations for you specifically in order to how to achieve your best health. Maybe you're not the average risk patient. Maybe you are a higher risk patient. And then it would be my job to make sure that you get to the right people, which would be my colleagues, Dr. Asamoah, Dr. Shalhoub, and Dr. Mehta. So as a primary care physician, that's really my role. However, I also have another role here, and I lead the colorectal cancer screening performance for primary care. And my role in that is to make screening for colorectal cancer easier for you. So I want you to achieve your best health, and I want to make it as easy as possible as well.
That's amazing. And so I guess as an internal medicine physician, what do you tell your patients about the importance of getting screened for colorectal cancer?
So a lot of my patients come to me because they want to know what they can do to really be proactive, improve their health, and how they can achieve their best health. And I think some of the best things that you can do are following up regularly with your doctor and to get your routine cancer screenings. As Dr. Shalhoub mentioned earlier, colorectal cancer is really unique because there's not just ways to detect it and treat it, but it's also one of the very few cancers we can actually prevent. If we can find these precancerous lesions, we can take them out so that cancer doesn't even develop in the first place. There's not very many things that we can do that for. If we have the ability to do that and improve your health, I say go for it, right?
And we've talked about the recommended options for colorectal screening. Can you talk a little bit more about that and the outreach that you're doing at MedStar Health to get people screened?
Yeah, so as my colleagues mentioned earlier, a colonoscopy is a great screening test because it's both can be used to find things and it can be used to treat as well. So we do encourage patients to get a colonoscopy because you can, test and treat at the same time. However, as Dr. Asamoah mentioned, for some people, it's hard to get a colonoscopy, right? And this might be due to not having someone to come with them after the effects of anesthesia or not having a ride from the colonoscopy. So for those patients that are average risk, there are other options that Dr. Asamoah mentioned, like a FIT test and a Cologuard. And at the end of the day, we want you to get screened so that you can have your best health. So if those options are better for you, then please get screened. We encourage it with, FIT, Cologuard, or colonoscopy. And at MedStar Health, we're trying to make this easier for our patients. So we're doing proactive outreach to let patients know that they're due for screening, because sometimes there is confusion about the guidelines. When do I get screened? How do I get screened? So we're trying to encourage patients to give them really that power and take initiative of their health, to let them know they're due for screening and it's time to do something about it. We encourage them to complete screening through the different types of screening that we just talked about. And for patients as well, we want to make it the easiest possible to do screening. So we are sending out Cologuard kits for patients as well, so that you don't even need to come to the office. For some patients who are eligible at average risk, you might have a Cologuard test being sent to your house.
Okay.
End of the day, we want to get you screened. We want to make it easier for you to get screened, and we want you to have the best health possible.
Yeah, that's really helpful. We do have a couple questions from our audience. So, Bill, thank you for your question. He asks, is there a difference between screening for colon cancer and colorectal cancer?
I'll take that, Amy. There's no difference. Colon cancer is the generic term for both colon and rectal cancer. Rectal cancer is just where the cancer is located, and the rectum is the bottom part of the colon. But colorectal cancer is it's a term, and colonoscopy is still the best screening test.
Okay, thank you. We have a question from Brenda. How much of a risk is it when your maternal grandfather had colon cancer?
Okay, so one of the elevated risk is definitely when you have a first degree relative like mother, father, or siblings. Uh, when you have a second degree relative like maternal grandfather or multiple family members, you're also considered somewhat elevated risk. So even under that situation, yes, I would recommend that you should go and discuss with your gastroenterologist to see when, if there are any other symptoms, if there are any other possible risks. There are some particular type of syndromes, as we discussed earlier, that there are some hereditary syndromes where some other cancers can also elevate the risk for colon cancer. So this is the knowledge that your gastroenterologist can help you guide through whether it is the right time for you to move forward with the screening process, where colonoscopy being the gold standard of it, or if there is any other test requires before as a step or whatnot. So reaching out to them would be the right thing to do.
Okay, I have a question. If you do have one of those, that first level of family that has had colorectal cancer, does the age get lower for when you should be screened? Did we talk about that?
No, I don't think we have had opportunity to talk about it, but that's an excellent question. So, if you have a first degree relative who was diagnosed with colon cancer, what we are interested in is we are interested in finding out what was the age of onset for the first degree relative, and then the family members, we try to start screening about 10 years ahead earlier than that.
Oh, okay.
Colon cancer takes several weeks to several months to apparently several years to grow. We have a reasonable understanding of how this disease is progressing or whatnot. So that's why we are more comfortable saying that, okay, we should start at around 10 years earlier, where perhaps we can just find that growth just in the polyp phase, and maybe we can just nip them from the bud, never allow that
Right.
polyp to ever turn into cancer.
Okay.
Yeah.
Thank you. We have a question from Michelle. If a first degree relative was found to have KRAS, colorectal cancer, and if you could tell me what that is, should there be genetic screening done in addition to more frequent colonoscopies?
Another very good question. So that is one of the gene that mutation with that is associated with the development of colon cancer. Uh, Definitely, I would say you need to discuss with your gastroenterologist. Okay, but this gives me a great opportunity to inform our viewers a couple other great opportunities that we have here at MedStar Health, which is our genetics department. There are two ways you can reach out to Lombardi Cancer Center, which is located at Georgetown University Hospital in Washington, D.C. We have an excellent team of genetics counselors. For the convenience part, for the most part, this counseling can be done just as a video visit. So you may not even have to go to the city for that matter. They can take a very good detailed history. What are the mutations they were found? They can plan out the family tree and so on and so forth. And then they can guide you whether you are at elevated risk, somewhat elevated risk, or you really need to get something done right now or whatnot. Uh, they also will be able to get you some blood work, which is where we can find out other type of potential mutation is present or not in the patient and or in the family. The other thing is that we also have an excellent colleague of ours, Dr. Priyanka Kant, who is dedicated GI genetics. She has long-term experience and research in this particular field, the GI malignancies. Uh, she also is welcoming patients to come and reach out to her, and then she can guide the same thing too. So there are two opportunities, two different ways, and obviously any of us are available. We can also help out with the guidance of the patient, and if needed, we can always discuss with our colleagues and get patient where they needed to get further evaluation.
Thank you so much.
You're welcome.
Back to Dr. Tran, I think I missed this one. Why is outreach so important?
Outreach is so important because for some people, it's hard to take time off work, and it's hard, like Dr. Men is saying, like sometimes traveling can be difficult for patients. So we really want to be able to meet patients where they're at. And that's the best way that we can work together to really achieve our health.
That's amazing. Thank you. Well, we've covered a lot of important information about colorectal cancer today, but before we wrap up, I'd love to hear from each of you the one key message that you'd like our viewers to remember from today's conversation. Can we start with you, Dr. Asamoah?
Hi, yes, of course. So I would say my key message is if you are 45, make sure you talk to your doctor about a colonoscopy or other colon cancer screening test. This procedure can help detect and remove precancerous lesions and also detect early cancers with better treatment options. I'll just add, my dad's first colonoscopy was at age 61, and he had colon cancer at the time.
Wow.
So it's one of these things that's really important for everyone, especially people at the age of 45. We're seeing so much colon cancer and these rates increasing that I think it's really important to get screened.
That's amazing. My husband turns 45 this summer, so I'll be getting on him to get his colonoscopy. Dr. Shalhoub, would you give us your key
Yes,
takeaway?
I always like to end with this very important point. Colorectal cancer is one of the few cancers that we can truly prevent and actually prevent, and it's through screening colonoscopies or any of the detection tests that Dr. Tran was talking about. We can detect cancers. Colonoscopies actually can detect and remove precancerous polyps before they really become cancer. So if you're 45 or older, don't wait. If you're experiencing symptoms, don't wait. Talk to your doctor right away, and just early detection really truly saves lives. Never ignore your symptoms, and a colonoscopy can save your life.
Yeah, I think a lot of people are really scared of the prep, but it doesn't sound that bad.
Yeah, it's a lot
And the
better.
alternative is worse.
Exactly. That was what I was going to say. And plus, it's very non-painful. The worst part of it probably is the prep when you're prepping at home, but it's worth saving your life for that, I think.
Right, right. And Dr. Mehta.
I agree with both of my colleagues here. I think they have already said that, and I'm going to stress it one more time. This is a preventable disease and preventable death. So please listen to your body when you're 45, even if you don't have any symptoms, you may feel you're healthy. That's all great, but it's time to get screened. Colonoscopy, as everybody said, is a gold standard. Talk to your family if you're able to, see if anybody has any issues with colon, or that will qualify you as an elevated risk, which may require you to get it checked earlier. And as always, we have a dedicated team of gastroenterologists here at MedStar Health. Reach out to any of us, and we will guide you further.
Thank you. Dr. Tran, we'll end with you.
And thank you, Amy. I just want to say thank you to my colleagues. Thank you for this time. And thank you for everyone that also tuned in. And I think by you tuning in shows that you care about your health. And this is one of the best things that you can do to help take care of yourself. So please take initiative. Please get your screening done. And we're here for you. We're here to help.
Thank you. Thank you to our panel of experts for sharing their time and expertise today. And thank you to everyone that joined us live. This was a great way to kick off Colorectal Cancer Awareness Month. If you'd like to learn more about your colorectal cancer risk, visit the link in the comments to take our free health risk assessment and explore additional resources from MedStar Health. If you found today's conversation helpful, please consider sharing this video with your friends or family who may benefit from learning more about colorectal cancer screening and prevention. We'll also be hosting more Facebook Live conversations throughout the month, so keep an eye out for those upcoming discussions. Thanks again for joining us, and have a great day.